So the article that I presented this morning is called Hyoscine butyl bromide for the treatment of death rattle sooner rather than later. And we started out basically with just a discussion about the death rattle and what it is and how distressing it can be for caregivers and for family members. Typically, we don't think that it causes any distress to the patient, but for those that are observing, it can be quite distressful.
Oh, yeah.
And so, what do we do about it? We talked a little bit about some of the anticholinergic options that are given, and the research shows that none of them are any superior to placebo or basically doing nothing. And so, if a patient is experiencing a death rattle, and it's common, I think, that they may ask, isn't there a new medicine we could give or something we could do? There can be, but the data, the evidence suggests that it's not going to be really any better than doing nothing. So it might help family members, but it also might worsen symptoms. Sometimes if you give somebody a medicine that completely dries them out, then they're more uncomfortable. If you give somebody a medicine that makes their secretions thicker, sometimes it can actually make the death rattle worse. So the journal article that I read investigates the question of whether giving an anticholinergic prophylactically would be beneficial. So the way the study was designed is they had people older than age of 18 who are entering the final stages of their life, who had some sort of impaired cognition or were under palliative sedation, but they had not had any anticholinergic medications. They were randomized to two groups. One group was a treatment group where they waited until the person developed the early stages of the death rattle and then gave them an anticholinergic medicine, this hyoscine butyl bromide, and then they monitored them every 6 hours until the patient died. The second wing was giving the hyoscine butyl bromide from the beginning and then monitoring them to see if they developed the death rattle.
So like from the beginning of the time they started to transition? Okay.
Yes. And the study found a couple different things. I thought that the most important thing was obviously being the evaluation of the death rattle. In the treatment wing, there was, I believe, 83 patients who were in the treatment wing who received hyoscine butyl bromide after they developed the death rattle. And of the 83, there were, I think, 51 patients that developed the death rattle. And in the prophylactic wing, where they looked at giving the hyoscine butyl bromide before they developed the death rattle, there were 51 patients in that wing, and only 3 of them developed the death rattle.
Oh, wow.
So the numbers for the development of death rattle are really exciting and favorable. However, there are some important limitations to this study. For one, it was not double-blind. It was not placebo-controlled. And then everything was based on the observations of the people doing the study and whether they observed the death rattle or not. So I think there's a really large possibility of
real
observation
subjective
bias.
Yeah.
Exactly. And so I thought that it was an important article because I think that the death rattle is distressing, and it's probably something that is going to continue to come up, and patients and families are going to ask about it. And I think that if they've had a negative experience with it in the past, or if they're requesting something prophylactically, I think it's a reasonable thing to offer, knowing that it might make the patient more uncomfortable or knowing that it might make secretions worse. If the family doesn't really have a strong preference or they don't bring it up, this is just my opinion, but I don't think it's worth offering because, number one, we don't know that they will develop the death rattle. Number two, these medications do cause known side effects that are quite unpleasant, and we would be subjecting them to that possibly without ever developing the death rattle. And so I finished the presentation this morning with just the introduction of another study. It's called the SILENCE study, where they are doing, and SILENCE is an acronym, SILENCE, for this super long title that I don't remember. But it's a study being done in the Netherlands, and they are looking at a randomized controlled, placebo-controlled, double-blinded study trying to answer the question of if prophylactic anticholinergics prevent development of the death rattle. And it's supposed to be done this year, 2019.
Oh, that's good.
So-
I think the Netherlands is very progressive about that stuff, about doing the studies. How did it talk about the time before, like when they started administering the high?
Yes.
Yeah.
So that's another interesting point that the article presents. So from the time that they started giving the medicine to the time that they developed the death rattle, they analyzed it, in those 6-hour increments. And actually the first two observations, one was 30 minutes after the onset of the study, one was 60 minutes after the onset of the study, and then they did every 6 hours. And for the treatment arm, they had people developing the death rattle within 1 hour and then continuously getting more and more prevalent over the next 48 hours.
So they might have actually caused the ones who had it?
Well, no, they didn't cause. They waited till it developed and then they tried to treat it. The ones that were treated prophylactically, of the 3 people that developed the death rattle, those 3 people all developed the death rattle about 48 hours into the study. And so whereas the treatment wing was seeing people with the death rattle, within an hour in some cases, the prophylactic wing didn't see anybody develop the death rattle for almost 2 days.
So they were given the anticholinergic, probably causing all that dryness. Yeah, that would be hard for me to do. Yeah, that personally, because knowing that how much an anticholinergic can,
So I thought it was interesting. I thought it was a simple but good article, something to think about.
I really recommend, I do things that are more like repositioning and things like that. That's what I usually recommend, because I haven't seen very much efficacy in any of the other drugs. So
I just remember a death rattle on a 40-year-old guy that the family would have done anything to end it. It was horrible. You could hear it outside on the curb. And it was like, and they're like, just make it stop. And I was like, oh my gosh, we'd have done anything to get that away.
I could see that.
Do you recommend suction? I think that's another thing we talked about.
I try not to, because I think that, again, it dries it out. You've got, you know what I mean, and it's kind of invasive for the person that's dying. So if they insist, I would send it. And that's usually, like you said, people who've had experience with it before, who have possible solutions because they think they've seen it work before. But I try not to. What about you guys?
No, we've always said no, just because it can either irritate more. I mean, it's more for the family's comfort, but it definitely doesn't put the patient in that more at ease.
Well, and I think that education in managing the expectations that this is just normal secretions, and the noise is terrible, but I think that if they know that making the person uncomfortable gets rid of the noise, so you got to balance what's good for the patient versus what's good for the family. So, but I get that in a 40-year-old too, especially where it's a young person dying.
Young person, tiny little kids running around, and we suctioned, we did atropine, everything. We repositioned. It was horrible, and that I've never seen such a prolonged active dying phase ever.
Because he was young.
How long was it?
Yeah, like 7 days. Wow. And Dr. Garner kept going out, I've never seen this. I've never seen this. It was just, and a fever of like 108. It was like, but he just wouldn't give it up.
Yeah. And
it was horrible. To the point where his toes were black and gangrene, and it started creeping in. We're like, oh my word. But anyway.
Oh, that'd be tough on the family.
Every now and then you just get this one that it's like, even I'm crazy.
Young, healthy people, though, I swear they can last forever. So.
Yeah. The second worst one I had was like a 15-year-old girl. Same thing. The family was like, oh my gosh, you can stop. We can't even be in there with her. We can't handle it. I'm like, no, we can't have that be the dying experience. Where she dies alone or behind a closed door because they can't handle the secretions. You know what I mean? So it's like, right.
That's when I would try anything.
There's got to be something.
Yeah.
So.
But did you ever get it? Did it ever help with the guy, the older guy, or the 40-year-old?
No, we suctioned and suction taught the family how to suction. It was buckets and volumes.
Really?
Yeah, it was like absolutely unmanageable.
I imagine somebody like that the prophylactic might have been a little bit more helpful.
But it's right. How do you know going into it? He's going to be the one.
Yeah.
But
did you try Trendelenburg position? Which is where that's something. Again, I don't have really any experience with this, but just sort of I talked with somebody who said, if you're able to elevate their feet and their body enough, so that way the secretions run up, and then you just turn their head and they'll drool, but at least it'll
be out.
Yeah. Well, we propped him on a side, because that particular bed we were able to do that. And we tried anything to just get it to drain on its own.
Oh, that's rough.
Anyway, I'm just saying, and that's certainly not the norm. But you get those outliers. It's like this is disturbing, so disturbing to the family, they don't even want to be at the bedside,
Yeah.
which is not how you want the patient to die. But but it's hard up front to know who's going to be that problem.
Mm-hmm.
It's absolutely hard. So most of it's not usually, typically it's not usually a problem. And then it doesn't occur on everybody. On those that it does occur, you can usually just reposition them, kind of do things to kind of make it kind of go to the background. But on these two in particular, it was horrible.
So as I was looking up the data on this study, I looked at the prevalence of the death rattle. And there's this big meta-analysis where they looked at a whole bunch of different studies analyzing how prevalent the death rattle is. And they concluded it was somewhere between 12 and 92%.
Oh, there,
Wow,
just,
that is a tiny little window.
you know that, they really
So maybe
wrenched that
almost
down.
everybody and maybe almost nobody.
Yeah, they really wrenched that down. Those are
Right.
great
Crazy
statistics.
results. Okay.
Right?
So do you, as a, I mentioned this,